Good morning, everyone, and welcome to our presentation on comprehensive electrocardiogram analysis and cardiac care. Today, we'll dive deep into understanding how to interpret ECGs, explore the fundamentals of cardiac physiology, and discuss the clinical applications that are vital for effective patient monitoring. I'm excited to share this important topic with you and look forward to exploring these key aspects together. Now, let's talk about understanding electrocardiogram analysis. When we interpret an ECG, we're really looking closely at the tracings to get a clear picture of how the heart is functioning. This means carefully assessing the heart's rhythm to see if it's steady or irregular, examining the shapes of the waveforms, and measuring the intervals between them. Each of these elements gives us important clues about the heart's performance as a whole, helping us detect any abnormalities or issues that might need attention. An electrocardiogram, or ECG, is essentially a way to indirectly measure the electrical activity happening inside the heart. This electrical activity is what controls the heartbeat, so by tracking it, we get valuable insights into heart function. For patients who are at risk of cardiac events or irregular heart rhythms, continuous ECG monitoring is crucial. It allows healthcare providers to watch the heart's activity in real time and respond quickly if anything abnormal occurs. There are different types of ECG leads used depending on the detail needed: 3-lead, 5-lead, or the more comprehensive 12-lead ECG. Each offers a different level of information, with the 12-lead being the most detailed for diagnosing issues. Speaking of diagnosis, the ECG is primarily a diagnostic tool to detect heart abnormalities. It helps identify serious conditions like myocardial infarctions, which are heart attacks, ventricular hypertrophy, meaning enlargement of the heart's ventricles, and various dysrhythmias or irregular heart rhythms. All of these detections are vital for timely and effective treatment. An electrocardiogram, or ECG, is essentially a way to indirectly measure the electrical activity happening inside the heart. This electrical activity is vital because it controls how the heart beats and pumps blood. For patients who are at risk of cardiac events or irregular heart rhythms, we use continuous ECG monitoring to keep a close watch on their heart's activity in real time. There are different setups for ECG monitoring, most commonly 3-lead, 5-lead, or 12-lead configurations, each providing a varying level of detail and perspective on the heart's electrical signals. The ECG is not just for monitoring, it's a crucial diagnostic tool. It helps us detect serious conditions like heart attacks, enlargement of the heart muscle, and various abnormal heart rhythms. Overall, the ECG is indispensable in cardiac care because it allows us to identify problems early and manage heart-related conditions effectively. An electrocardiogram, or ECG, is essentially a way to measure the heart's electrical activity indirectly. It captures the electrical signals generated by the heart as it beats, giving us important insights into how the heart is functioning. For patients who are at risk of cardiac events or irregular heart rhythms, continuous ECG monitoring is crucial because it helps detect problems early and allows timely intervention. There are different types of ECG leads that can be used depending on the situation: 3-lead, 5-lead, and the more comprehensive 12-lead configurations, each providing varying levels of detail about the heart's activity. The diagnostic power of an ECG is significant. It helps identify conditions like heart attacks, ventricular hypertrophy, and arrhythmias. Overall, ECGs are an indispensable tool in medical practice, offering a straightforward and efficient method for monitoring and diagnosing heart health. The 12-lead ECG is a fundamental tool we use to capture the heart's electrical activity from multiple perspectives. It records signals through 12 leads, 6 placed on the chest, which show us the heart's activity across the horizontal plane, and 6 limb leads that give us views from the frontal plane. This combination allows us to get a comprehensive picture of the heart's function. By analyzing these leads, we can assess important aspects like heart rate and rhythm, detect abnormalities in electrical conduction, and identify conditions like arrhythmias, ischemia, or infarctions. It's a critical diagnostic method used not only in hospitals, but also in clinics and emergency situations to provide timely, life-saving information about cardiac health. Understanding how to interpret these features helps us make accurate and informed decisions for patient care. An ECG is incredibly valuable because it gives us important information about a patient's cardiac status, especially when they show signs or symptoms that might indicate heart disease. It helps us understand what's going on with the heart at that moment. Additionally, an ECG is a great tool for monitoring how the heart responds over time, whether to treatment or changes in the patient's condition. However, it's important to remember that an ECG has its limitations. For one, it doesn't measure how well the heart is actually pumping blood. That's a key function the ECG can't assess. Also, while it provides a snapshot of current electrical activity, it doesn't predict the likelihood of a future heart attack. Despite these limitations, the ECG remains a critical part of clinical assessment and ongoing monitoring for patients who might have or are known to have heart problems. An ECG should be obtained whenever there are signs or symptoms suggesting a cardiac disorder, whether acute or chronic. This helps us identify any underlying heart issues that need attention. In cases of acute cardiac events like a heart attack, angina, or congestive heart failure, an ECG is essential to quickly evaluate the heart's condition and guide immediate treatment. It's also important to perform an ECG before surgery as a screening tool to assess the patient's overall heart health and reduce potential risks during the procedure. Additionally, when respiratory medications are being administered, an ECG can reveal any special considerations or side effects related to these drugs, ensuring patient safety throughout treatment. When we consider when to obtain an ECG, certain clinical findings should prompt us to take this step. First, chest pain that's centrally located and may radiate to the shoulder or back is a key red flag. This type of pain often signals cardiac involvement and needs immediate evaluation. Next, dyspnea on exertion, especially in patients over 40, is important. Shortness of breath during physical activity can indicate underlying heart problems that an ECG can help detect. Signs of heart failure also warrant an ECG. Symptoms like orthopnea, difficulty breathing when lying flat, paroxysmal nocturnal dyspnea, which is sudden nighttime shortness of breath, and pedal edema or swelling of the feet are classic indicators. Unexplained fainting spells are another concern, as they could reflect arrhythmias or other electrical issues in the heart that an ECG can reveal. Palpitations, or the patient's awareness of irregular or rapid heartbeats, should not be ignored either. And finally, persistent, unexplained nausea in high-risk patients, those with known risk factors for heart disease, can sometimes be a subtle sign of cardiac ischemia. In all these cases, an ECG is a valuable tool for diagnosis and guiding further management. When we see certain clinical signs during a physical examination, it's important to consider obtaining an ECG to help guide diagnosis and management. Some key findings include unexplained tachycardia, especially when the patient is at rest, since it suggests possible underlying cardiac stress or dysfunction. Hypotension and decreased capillary refill point towards compromised circulation, which can be critical. Abnormal heart sounds or new murmurs raise suspicion for structural heart issues, while pedal edema indicates fluid retention, often linked to heart failure. Cold or cyanotic extremities can signal poor perfusion, and diaphoresis might suggest sympathetic nervous system activation due to cardiac distress. Jugular venous distension is a strong sign of increased central venous pressure, and changes in mental status or abnormal sensorium can reflect poor cerebral perfusion. Lastly, bilateral inspiratory crackles heard in the dependent lung zones often indicate pulmonary congestion. Together, these findings emphasize the need for an ECG to evaluate the cardiac status thoroughly. The heart is made up of 4 chambers, 2 atria at the top and 2 ventricles at the bottom. These chambers are divided down the middle, creating a right side and a left side. On the right side, the atrium and ventricle work together to receive venous blood, which is low in oxygen, and pump it to the lungs for gas exchange. Once the blood is oxygen-rich, it returns to the left atrium and ventricle, which then pump it out to the entire body. This continuous circulation ensures that oxygen and nutrients are delivered efficiently, supporting all the tissues and organs we depend on. Understanding this basic structure and function is key to grasping how the heart keeps us alive and healthy. The heart is made up of 4 distinct chambers that work together to keep blood flowing efficiently. These chambers are divided into 2 atria and 2 ventricles. The atria are the upper chambers, and the ventricles are the lower chambers. The heart itself is split down the middle into right and left sides, each with its specific functions. On the right side, the atrium and ventricle receive deoxygenated blood coming from the body and send it to the lungs so it can pick up oxygen. Meanwhile, the left side of the heart receives this oxygen-rich blood from the lungs and pumps it out to supply the entire body. Understanding this division of labor is crucial to grasping how the heart supports circulation and overall physiology. Let's talk about the cardiac muscle, which is also known as the myocardium. This is the muscle that makes up the heart and is responsible for its pumping action. The contraction of the myocardium happens because of electrical stimulation. Essentially, electrical signals trigger the muscle to contract and pump blood. Now, the myocardium isn't just any muscle, it has a unique structure. It contains special pacemaker and conducting cells that coordinate these electrical signals, ensuring the heart beats in a regular and efficient rhythm. These specialized cells are critical for maintaining a consistent heartbeat. The heart's electrical activity begins in the sinoatrial or SA node, which acts as the natural pacemaker because it has the highest level of automaticity. From there, the electrical signal spreads throughout the atria, traveling along internodal pathways to reach the atrioventricular or AV node. One crucial function of the AV node is to delay the signal briefly. This delay ensures the atria have enough time to fully contract and push blood into the ventricles before the ventricles themselves contract. After this pause, the electrical impulse moves from the AV node down to the bundle of HIS, which serves as the main conduit for the signal as it descends through the heart's conduction system. Finally, the signal reaches the right and left bundle branches and is distributed through the Purkinje fibers. This last step guarantees that the ventricles contract in a coordinated and efficient way, pumping blood out to the lungs and the rest of the body. The human heart is made up of 4 chambers, the right atrium and right ventricle, along with the left atrium and left ventricle. These chambers are separated by valves that ensure blood flows in the right direction and prevents any backflow. The cardiovascular system plays a crucial role in circulating blood throughout the entire body, delivering oxygen and nutrients to our tissues while also removing waste products. A key part of this process is the heart's electrical system, which controls the timing of contractions, allowing the heartbeats to be well coordinated and efficient. This synchronization is essential for maintaining proper blood flow and overall cardiovascular function. Depolarization in an ECG happens when the heart cells are stimulated. This process represents a sudden loss of the negative charge inside those polarized cells, which triggers the muscle to contract. Essentially, it's the electrical signal that tells the heart to beat. Repolarization, on the other hand, is the process where those cells regain their negative charge. This marks the heart muscle relaxing after contraction and is a vital part of the heart's electrical cycle, allowing it to prepare for the next beat. Now, the ECG tracings we see on the monitor are actually recordings of these waves of depolarization and repolarization moving through the heart muscle, or myocardium. Each wave has distinct characteristics we can identify and analyze, and this helps us gain important information about how well the heart is functioning. Understanding these basic waves is key to interpreting the overall heart health. The P wave on an ECG represents atrial depolarization, which is essentially the electrical activity that triggers the atria to contract. Next, the PR interval is really important because it measures the time it takes for the electrical impulse to travel from the atria to the ventricles. This interval normally ranges from 0.12 to 0.2 seconds. During this time, the atria are contracting and effectively priming the pump, which means they're helping fill the ventricles with blood before those ventricles contract. This coordination is crucial for efficient heart function. Now, let's look at the basic ECG waves, starting with the QRS complex. This represents ventricular depolarization, which is essentially the electrical activity that triggers the ventricles to contract. It's a very quick process, normally happening in less than 0.1 seconds. Next, we have the SD segment. This part of the ECG occurs between the end of the QRS complex and the beginning of the T wave. It's important because changes here can indicate issues like ischemia or injury to the heart muscle. Finally, the T wave represents ventricular repolarization, which is when the ventricles recover their electrical state and get ready for the next heartbeat. Understanding these waves is crucial because they tell us a lot about the heart's electrical function. The electrocardiogram paper captures the heart's electrical activity using a grid pattern made up of small boxes outlined by light and dark lines, both horizontally and vertically. Along the horizontal axis, time is represented. Each small box, which measures 1 millimeter, corresponds to 0.04 seconds, while a larger box made up of 5 small boxes equals 0.2 seconds. So when you count 5 large boxes across, that translates to 1 full second. On the vertical axis, the paper measures voltage or amplitude, which reflects the strength of the electrical signals generated by the heart. Understanding these measurements is key to interpreting the ECG accurately. When we talk about interpreting an electrocardiogram, or ECG, we're looking at the heart's electrical activity. This is more than just a picture. It's a detailed story of how the heart is functioning. To understand this story, we carefully examine the heart's rhythm and how electrical impulses move through it. Key elements we focus on include the P waves, QRS complexes, and T waves, each representing different phases of the heart cycle. Mastering this process is essential because it helps us accurately diagnose a range of conditions, from arrhythmias to heart attacks and even electrolyte imbalances. This makes ECG interpretation a vital skill in clinical practice. When we talk about normal sinus rhythm, the first thing to consider is the heart rate, which typically ranges from 60 to 100 beats per minute. This means the heart is beating at a steady and healthy pace. Next, the rhythm itself should be regular, showing consistent spacing between each heartbeat. Now, looking at the P waves, they should have a normal shape and always be followed by a QRS complex. This indicates that the electrical impulse is properly originating from the sinoatrial node and traveling through the heart as it should. The PR interval, which represents the time it takes for the electrical signal to move from the atria to the ventricles, should last between 0.12 to 0.2 seconds. This interval is crucial because it ensures the atria have enough time to contract before the ventricles do. Finally, the QRS complex, which reflects ventricular depolarization, must have a width of less than 0.1 seconds. A narrow QRS complex suggests that the electrical impulse is being conducted normally through the ventricles. Altogether, these features confirm a healthy and efficient heartbeat typical of a normal sinus rhythm. Sinus bradycardia is essentially a normal sinus rhythm, but it's slower than what we typically expect. The key feature here is the heart rate. It's less than 60 beats per minute, which is slower than the usual range. Despite this slow rate, the rhythm remains regular, meaning the timing between heartbeats is consistent. When we look at the P waves, they appear normal, and importantly, each P wave is followed by a QRS complex, showing that the electrical signal is properly conducted through the heart. Additionally, the PR interval, which is the time from the start of the P wave to the start of the QRS complex, stays within the normal range of 0.12 to 0.2 seconds. The QRS complex itself is also normal in width, measuring less than 0.1 seconds. All these features together define sinus bradycardia as a slower, but otherwise typical heartbeat pattern. Sinus tachycardia is essentially a form of normal sinus rhythm, but with an elevated heart rate. Specifically, the heart beats faster than usual, ranging between 100 and 150 beats per minute. Despite this increase in pace, the rhythm remains regular and consistent. When we look at the electrocardiogram, the P waves appear normal and are always followed by a QRS complex, indicating proper atrial and ventricular conduction. The PR interval stays within the typical range of 0.12 to 0.2 seconds, and the QRS complex remains narrow, less than 0.1 seconds wide. So, while the heart is racing, sinus tachycardia still follows the usual patterns we see in normal sinus rhythm, with the main difference being the speed of the heartbeat. Atrial flutter is characterized by a distinct, rapid sawtooth pattern that you can see clearly between the normal QRS complexes on an ECG. The atrial rate in this condition is quite fast, typically ranging from 180 to 400 beats per minute, which is significantly higher than normal. However, the ventricular rate is slower than the atrial rate because not all the atrial impulses are conducted to the ventricles. The rhythm itself tends to be regular, and the P waves take on that classic sawtooth shape, appearing uniform throughout. When we look closer at the electrocardiogram, the PR interval isn't measurable because of the continuous atrial activity, and the QRS duration remains normal, usually less than 0.1 seconds. These features together help us identify atrial flutter accurately. Atrial fibrillation is defined by a chaotic baseline visible between the QRS complexes on an ECG. When we look at the heart rate during atrial fibrillation, it tends to be variable, so it's helpful to count the QRS complexes in a 6-second strip to estimate the rate. The rhythm is described as irregularly irregular, meaning there's no consistent pattern to the beats. Instead of distinct P waves, you'll see fibrillatory waves that change in shape and appearance throughout the strip. Because of this, measuring the PR interval isn't possible since consistent P waves are absent. Lastly, the QRS complexes themselves remain narrow, typically less than 0.1 seconds in width, indicating that ventricular conduction is usually normal despite the irregular atrial activity. Premature ventricular contractions, or PVCs, occur when the normal heart rhythm is interrupted by an early beat originating in the ventricles. You'll notice that the QRS complex during a PVC is wider than usual, greater than 0.1 seconds, and it's not preceded by a P wave. Additionally, the T wave following this wide QRS is inverted. Even though the PVC interrupts the rhythm, the overall heart rate still corresponds to the underlying rhythm, meaning the PVC doesn't change the rate, just the timing of individual beats. Normally, the heart rhythm is regular, but it gets disrupted by these early PVCs. Regarding the P waves, they are not linked or associated with the PVC itself. The PVC occurs independently of atrial activity. Because of that, the PR interval, the time between the P wave and QRS complex, can't be measured for the PVC beat. Finally, some key characteristics to remember. These QRS complexes are premature, meaning they happen sooner than expected, are abnormally shaped, and wider than normal. After each PVC, there's usually a compensatory pause, a brief delay before the next normal beat resumes the rhythm. This pause helps the heart reset its timing after the early beat. Premature ventricular contractions, or PVCs, have some distinct characteristics that set them apart. First, their QRS complex is wide, lasting more than 0.1 seconds, which is longer than normal. Importantly, PVCs are not preceded by a P wave, and the T wave following the QRS is typically inverted. When we observe the overall heart rhythm, the rate usually follows the underlying rhythm, but the regular pattern is interrupted whenever a PVC occurs. This interruption is important because it shows how PVCs cause irregularity amid an otherwise regular rhythm. Regarding the relationship with P waves, these contractions are not linked to the normal atrial activity. There is no P wave before a PVC, which highlights that the beat originates independently of the atrial signals. Looking at the intervals, the PR interval can't be measured during a PVC since the contraction originates outside the normal conduction pathway. This confirms the disconnection from the atria's role in initiating the heartbeat. The shape or morphology of the QRS complex during a PVC is both premature and abnormal. It's wider than usual and different in configuration, often followed by a compensatory pause, where the heart resets before the next normal beat. Finally, PVCs are ectopic, meaning they arise from an abnormal site, specifically, somewhere in the ventricles rather than the atria or the normal conduction system. This ectopic origin explains their premature nature and unusual pattern on an ECG. Ventricular tachycardia is characterized by a rapid sequence of wide QRS complexes without visible P waves. The heart rate typically ranges between 140 and 300 beats per minute, which can be alarming since the patient may actually have no detectable pulse despite this fast rhythm. The rhythm itself is generally regular, meaning the beats occur at consistent intervals. One key observation is that P waves, if present, are not linked to the QRS complexes, indicating a loss of normal atrioventricular coordination. On the ECG, the PR interval cannot be measured, and the QRS complexes are abnormal, usually wider than 0.1 seconds, reflecting their ventricular origin. These features help us identify and differentiate ventricular tachycardia from other arrhythmias. Ventricular fibrillation is marked by a completely chaotic and irregular electrical activity within the ventricles. Unlike a normal heartbeat, the rhythm here is extremely disorganized, with waves that lack any clear pattern. One key point is the absence of P waves, which means we don't see the usual atrial signals. Additionally, because of this chaotic activity, no measurable heart rate can be detected. Finally, the QRS complexes, which normally represent ventricular contraction, are either missing or show up as small, sporadic waves with very low amplitude. All these factors together make ventricular fibrillation a critical and life-threatening condition. Asystole is essentially the absence of any electrical activity in the heart, which is why on an ECG we see a straight or almost flat line. This means there is no heart rate at all, no beats happening. When we analyze the rhythm, there's none to detect because the heart isn't generating any electrical impulses. Similarly, there's no atrial activity, so we don't see any P waves. And finally, the ventricles show no activity either, meaning there are no QRS complexes present. It's a critical condition that indicates the heart has stopped functioning electrically. Here, we're looking at the key signs that point to cardiac ischemia or infarction. One of the main indicators is a depressed ST segment, which means it's at least 1 millimeter below the baseline on an ECG. Another important sign is the inversion of T waves, which is a strong marker of ischemia. The good news is that at this stage, the cardiac injury might still be reversible, so timely and appropriate treatment can make a real difference. By carefully monitoring these characteristic changes on the ECG, specifically the ST segment depression and T wave inversion, healthcare providers can intervene quickly to help prevent further damage to the heart. Myocardial infarction, commonly known as a heart attack, occurs when there is death of heart muscle due to insufficient blood flow. This lack of oxygen causes permanent damage to the affected tissue. One of the key ways we identify this condition is through changes on the ECG. Typical findings include elevated ST segments and alterations in the T waves, which signal that the heart muscle is under stress or has been injured. A specific type of heart attack, known as ST elevation myocardial infarction, or STEMI, is characterized by a distinct elevation in the ST segment on an ECG. This signifies a complete blockage of blood flow to a part of the heart, requiring immediate medical attention. Patients experiencing a STEMI often report chest pain, which can be severe and may radiate to other areas such as the neck and jaw. Recognizing these symptoms quickly is crucial for prompt diagnosis and treatment to minimize heart damage. When assessing chest pain, it's crucial to start by asking the patient about the onset, specifically when the pain began and whether it came on suddenly or gradually. Understanding what triggers or worsens the pain can give us important clues, so we need to explore any activities, positions, or factors that provoke the symptoms. Also, ask the patient to describe the quality of the pain, whether it feels sharp, dull, burning, or crushing. Next, we need to evaluate the severity and duration of the pain. Find out if the pain radiates to other areas, like the arm, jaw, or back, as this can indicate cardiac involvement. Having the patient rate their pain on a scale from 0 to 10 helps quantify how intense it really is. Also, determine if the symptoms are acute, meaning they started recently, or if they've been ongoing over a longer period. Finally, it's essential to act quickly and be cautious about misdiagnosis. If the chest pain doesn't improve with nitroglycerin, we should strongly suspect an acute myocardial infarction. Time is critical. Acting promptly can save heart muscle and improve outcomes. So, ensure treatment interventions are started without delay to reduce potential damage. Many patients with COPD show notable changes on their ECGs, which is something we need to keep in mind when interpreting their results. One major factor contributing to these changes is lung hyperinflation, which causes the diaphragm to flatten. This physical change pushes the heart into a more vertical position within the chest. Because of this shift, we often see a clockwise rotation on the ECG, along with right axis deviation. Another important aspect to consider is pulmonary hypertension, which is common in COPD and can lead to enlargement of the right side of the heart, a condition called cor pulmonale. Understanding these patterns helps us better assess and manage the cardiovascular effects associated with chronic lung disease. When it comes to chronic lung disease, one important factor to consider is hypoxemia, which is a low level of oxygen in the blood. This condition can lead to dysrhythmias or irregular heartbeats. In addition to the effects of hypoxemia itself, some medications used to treat obstructed airways can also cause dysrhythmias as a side effect, so it's something we need to monitor closely. Another key point is the increased risk of dysrhythmias during the night, especially in patients with COPD. Their hypoxemia tends to worsen during sleep, which in turn raises the likelihood of nighttime dysrhythmias. This means that managing oxygen levels carefully during sleep is critical for these patients to reduce cardiac complications.